But I was also wondering that Dr. Sana attended the session and we kept asking them if they had any questions and they didn't.
They
Uh,
said no, and then suddenly they put on
yeah,
the group that what's the difference between pars and pedicle
yeah, that's okay.
screws. So
Okay, so I'm muting myself and then you can continue.
So let's start. I was not in favor of this session of OC fusion because if someone knows that the C1, C2 fusion, then there's an addition of that you have to put a screw in the occipit, nothing else. To me, nothing, any additional thing in that. But Dr. Kamal emphasized that you have to do the OC fusion. In this way, we will complete the craniovertebral junction in a proper way. So maybe it's a better uh, thoughts of the Dr. Kamal. So that's why I'm here with the OC fusion with you people. So Atlanto-Occipital dislocation and fusion. Actually, there are two main important things when we talk about the whole craniovertebral junction. One is the bony structure, and second is the ligamentous part of the craniovertebral junction. The ligamentous part is more important when we say because they have the good in the stabilization. When they become injured, then there is a lot of problems in the craniovertebral junction. Most craniovertebral junction injuries, they are because of the ligamentous. On the basis of this ligamentous, we decide that it is a stable fracture, this is an unstable fracture, this is a stable injury, and this is an unstable injury. So this is the main thing. Same like of C1, C2 fusion, we have to see of the craniovertebral junction of OC1, like the C1, C2, a lot of ligaments were there. The most important one, that of the transverse atlantal ligament. When we talk about the occipital cervical C1, there are two main important ligaments are there. When see the posterior atlanto-occipital membrane, this is the posterior atlanto-occipital membrane. You can see here. Okay, look at here. That is attached posteriorly at the C1 arch and occipit. And second thing, that is the anterior atlanto-occipital membrane that is attached anteriorly to the anterior arch of the C1 and then the clivis. These two important ligaments are there. And second, that is the additional ligament that is important. These are called, what are these ligaments? Yes, please. What is this ligament? Anyone who can tell? Yes. This is LR ligament. This is called LR ligament. Actually, it is not direct attached to the C1 and C2. It is attached to the odontoid, and then it goes upward to the inner side of occipit. It is attached. But due to occipital attachment, it gives a lot of, you can say, the stability of the craniovertebral junction. So these are two main ligaments are there. Look at here. This is a LR ligament. This is odontoid. It's attached bilateral to the odontoid. Then goes upward to the inner side. It attaches with the occipital bone. Okay, so that's why these important ligaments are there. And this is transverse frontal ligament. That is very important. Previous lecture and sessions we have discussed about in detail about the transverse frontal ligament. So when we talk about the OC fusion, actually, it is mostly indicated in the occipitocervical. You can say the dislocation. When we talk about the Atlanto-Occipital, actually the AOA spine, they classify the Atlanto-Occipital not as a single entity that we call the occipitocervical dislocation. Okay, so this is not only the Atlanto-Occipital dislocation only, that we call it the single injury, then we need the OC fusion. Actually, it starts from, you can say, the any injury that is injury related to the bony structure of the region of the Atlanto and C1. Any ligamentous injury that is associated with the occipito-atlantal, and then Atlanto-occipital dislocation. So this is continuation and severity of injury. That's why AO Spine classify these injuries into three classes. That the number one single class is that it starts from that the isolated fracture of the condyle. Look at here. It's the isolated fracture of the condyle. It is unilateral, linear, that is okay. It is stable fracture. When it is bilateral and multiple fractures are there, then it is unstable. This is type 1 classification of the, you can say, the craniovertebral occipitocervical. And second injury is that is type 2, that is a bit severe as compared to type 1, that is the ligamentous injury. When the ligaments are disrupted, the most important ligaments, those are, that is LR ligaments, bilaterally when they are disrupted, it is called type 2 injury. When they become disrupted, actually what they cause is, because one end of them, it is associated with the condyle, though the lower end is not associated with the C1, but the upper end it is associated with the condyle. When the bilateral become disrupted, this condyle can become the displaced and it causes the Atlanto-occipital dislocation. Atlanto-occipital dislocation is mainly because of the ligamentous injury. And secondly, it is rare that is because of any type of, you can say, that is the bony one. When these two ligaments become disrupted, the the condyle, or you can say the occipit become free. It is not too much associated with, there is no strong stability factor that can combine the occipital with the cervical area. That's why they causes the dislocation. When they become bilaterally, initially the patient is immobilized externally. If it is not being cured, then definitive surgery is required because there is a ligamentous injury is associated. This is one factor. Second thing is that when these bilateral ligaments injury are there and there is no any deficit, then we call the same injuries type 2. This was type 1. This is type 2, Atlanto-occipital injury. But what happens when this bilateral ligamentous disruption is there and there is associated neurological deficit, though there is no any dislocation of OC, but again, then we call it type 3. That is similar to that of occipital cervical dislocation. Then we will be type 3 and it will be definitive surgery, and that surgery is emergency. You have to fix and fuse as soon as possible because the mortality is very high in these kind of the patients of the occipital cervical when they become severe. About 30 to 40% mortality is there. So when the ligaments are disrupted associated with the bone, this is the picture that is type 3 that we call Atlanto-occipital dislocation. Okay, Atlanto-occipital dislocation. Atlanto-occipital dislocation is of 3 types: type 1, type 2, type 3. Anyone who can name this classification? What is the name of the classification of Atlanto-occipital dislocation? Anyone who can name? Megrel. Who said that there is a name of classification is the Megrel? Who said? Megrel is a technique, this is not classification. I think so. But whatever I remembered. Yes? Anyone? Dr. Sana?
Yes, sir. Sir, I have opened the
Dr.
book.
Yusuf,
That's
Dr.
why.
Salim, Dr. Yusuf.
Trinals.
Sorry?
Trinals. Trinals.
Yes, you are right. Anderson and D. Alonso is not classification of rotate this one. Field and Hawking is not a classification of Atlanto-Occipital dislocation. It's a classification of Atlanto-axial subluxation. That are of three types: anterior, rotational, and the posterior. I am talking about Atlanto-occipital dislocation, not Atlanto-occipital subluxation. Oh, sorry, not about the Atlanto-axial subluxation. Fielding and Hawking
Journalist?
classification is about the Atlanto-axial subluxation, I think. Then someone says that trial length classification of yes. Trial length and trianalysis classification of Atlanto-occipital dislocation. So this says there are three types of Atlanto-occipital dislocation. What is this one? What's the type of this one? It is anteriorly displaced, it is posteriorly displaced, or it is, you can say, the vertical or longitudinal.
Anterior.
Anterior displacement. What is anterior displacement? We talk about this one is the anterior displaced, that is occipit, not the C1.
Posterior.
This classification is based on the displacement of, you can say, the occipit, or you can say the clivus, or you can say the condyle. They have the movement anteriorly moved and displaced. C1 is at the same joint. Look at here. This is anteriorly displaced. It is posteriorly displaced. This one, the C1 at the same place, and this is vertically placed above. It is gone above. So there are three types: anterior displacement of the occipit, posterior displacement, and vertical displacement, that is called longitudinal displacement of this one. Okay, when we see the MRI or CT scan of these three classifications, you can easily see I start from the left side to the right, that is normal area. Look at here. This is our anterior arch of the C1. This is the posterior arch of the C1. And this is the opistheon. You can say this is foramen magnum area. This is occipit area, and this is clivus. Normally, it is somewhat at the same vertical side of the, you can say, the placement of C1 odontoid and the clivus as well. Look at here. And when we are seeing and when we are going for the Atlanto-occipital dislocation, not only go to the mid-sagittal section. This is mid-sagittal section in which we are seeing only odontoid, anterior arch, and the clivus, and the posterior occipit and posterior arch. You have to also see the joint site is there, because mostly this is the joint displaced are there. Joint means occipito cervical, occipitoatlantal joint dislocation is there. So that's why you have to also see that one. Look at here. This is a normal picture of mid-sagittal of the cervical craniovertebral junction, and this is at the level of joint. This is occipital bone, condyle, and this is C1, and this is joint area is here, that we call it the occipito craniovertebral junction, that is our alignment. When we see this one, it is anteriorly displaced. Look at here. Normally it is here, and this is anteriorly displaced. Anteriorly displaced. Look at this joint. It has been dislocated, anterior displaced, and there is you can say some kind of a subluxation over there. Anterior displacement is there. In type 2, when we are seeing this, later on we will see what are the criteria of longitudinal and anterior and the posterior displacement. What are the measurements are there? It is going apart longitudinally above, longitudinally over there, and the distance between these two, that is we call, that is the BDI, that has been increased. So look at here, this one, okay? So it has been increased now. Look at here, this has dislocated, and vertically longitudinally dislocation is there. When we talk about the posteriorly, the clivus and the occipit is gone posteriorly. This is normal alignment. There's posterior arch, and you can say the opistheon is there, and they are in alignment to somehow. But look at here, there is so much displacement posteriorly, and the chyle it is called posterior displacement. And when we see the joint, it is significantly posterior displaced. So according to this classification, we have seen that there are three types: anterior, posterior, and longitudinal displacement. Okay. How we have to do the measurement and come to know that these are displaced or not? One thing that is what is shown here. Anyone? What this measurement we call?
Powers ratio.
Who's there? Who is with me?
Powers ratio.
Yes. Sorry?
Powers ratio. Powers ratio.
Yes, you are right. Excellent power ratio. But who is with me?
Dr. Salim Habib. Salim Habib or Salim Habib, I'm not sure.
Okay, Dr. Salim or Salim? So excellent, Dr. Salim or Salim. Yes, you're right. Power ratio. Can you elaborate this one, please?
There's a distance from the opistheon to the posterior surface of the arch, the axis, and then the basal to the opistheon. Basal to the posterior axis, and then
A is basal. Yes, you're right.
And then opistheon to the anterior surface of the anterior surface of the axis.
Okay,
CD.
you are right. Excellent. Thank you. So there are 4 points that we have to see and measure. That is that we call the clivus, that is called the basal, and this is C, that is called we call it the opistheon, and the posterior arch of C1 and anterior of C1. These are the 4 points. We draw a line from basal to the posterior arch. That is this one. This is. And second thing is that second measurement is from opistheon to anterior arch C1. OA, and that we call opistheon to anterior arch of C1. OA, opistheon anterior arch of C1. And this is the B, and this is posterior arch C1. What we call it? AB, it is written here AB. So this is called power ratio. What is the significance of this power ratio? Yes, please. How much it is significant? How much power ratio is significant? Yes, you're right. Power ratio is 1. If more than 1, that is significant. Then we can say there is Atlanto-Occipital dislocation. Okay? It's Atlanto-Occipital dislocation. And each and every, you can say the type have different measurements over there. And second thing is that is called the CCI. That is called the CC. That is this diameter is important. This is the condyle. That is called the occipital condyle. The distance between the occipital condyle and CC1. Sorry, the occipital condyle and C1. That is the distance. We have to measure that distance. That is significant. And mostly this distance is increased vertically when there is a longitudinal displacement is there. But when we can see that it is moving apart, it means it is going to start, the dislocation is there. This CC1 is important in the longitudinal one. When we see the longitudinal, previously we have seen there. What should be the normal diameter of this one, the condylar and C1? Yes.
1 to 2 millimeters.
Who is there?
Dr. Abid Shehzad.
Dr. Abid Shehzad. Okay, 1 to 2 mm. I think the cutoff value is 2 mm.
1 to 2 mm is normal. Yes.
If more than 2 mm, then it is significant. Yes? Am I right?
Yes, sir.
Anyone who can correct this one properly if there is something is there?
Sir, book less than 2 millimeter in adults on plain X-ray and less than 1.4 millimeter on CT.
It means when we
Not
see CT, that is about 4 mm, less than 4 mm. But when we talk about the X-ray, that is less than 2 mm.
Sir, 1.4 mm.
1.4 mm.
Yes, sir, on CT.
In CT. Okay. So thank you. Let's see later on that if someone has these measurements, kindly share in the group. Maybe I have forgotten about these two. What I remember that its cutoff value is 2. If more than 2, Dr. Abid Shehzad has told that 1 to 2 mm, it's right. But if the more than 2 mm, then we consider that there is a dislocation is there. Okay, we'll see. And second is the PAL ratio. What is PAL? What is PAL and the Bayesian? Yes. Anyone? Adult less than 2 mm. Okay. Thank you. Dr. Kamal Harris line. It's also called Harris line. Posterior axial line. That is called the posterior. PAL stands for the posterior axial line. Axial stands for C2. And this line that is also called the Harris line. We start from the posterior, that vertebral body of, you can say the C2 goes upward. Then at the level of pelvis, we see this line. Then we consider this one, that is important in the anterior dislocation. Look at here, it is how much going anteriorly that is displaced. Okay, so this is again significant in the anterior one. When you talk about these two, that is the BDI from the Bayesian to the dental interval is there, that is increased. It increased into two types of the dislocations. Which dislocations? Two types? Mostly in one dislocation. Yes, sorry. Sorry, one dislocation. This BDI will be increased when? In which type of dislocation?
Anterior.
How anterior? Dr. Sana is there?
Sir,
No,
vertical
Dr.
mostly.
A BDI is increasing, it means there is a longitudinal displacement. There's a vertical displacement. Yes, right.
Vertical longitudinal, yes, sir.
When the BDI is being increased, it means this distance from the Bayesian to dental interval is increased. It means mostly there is a kind of, you can say, the longitudinal vertical displacement. Okay, this is the ratio on PAL we mostly see. You can say that when there is anterior displaced is there, and when the posterior will be there, we'll see this relation to this one. I have the idea that when there is another measurement is there, I forgot that one. Anyone who remember that was mentioned in the, I think, Greenberg. That is called
ABI?
no, not ABI. I will share with you guys. So these measurements are important. By this way, we can see the displacement or not. So then we will consider that there is a and which of this one. BAI is another thing, but there's a craniometric points are there. There are about 5 to 6 points according to that. That is the measure that we decide on that points that it is being dislocated or not. I will share with you when I remember that one. We have seen this one, that posterior dislocated, vertical dislocated, anterior dislocated. So what we have to do, suppose that there is a ligamentous injury bilaterally, and then there is a type 2. We have discussed that the cranio-occipitocervical dislocation type 2, in which there is a bilateral ligamentous injury is there, that is shows instability. And second thing, that when we see any type of these one, anterior, posterior, and longitudinal dislocation has been confirmed and diagnosed, then there is approach is definitive surgery. When there is isolated condyle simple fractures there, we can immobilize external immobilization with the help of collar, that is called Philadelphia. Then we repeat the patient's X-ray. Can you apply the traction in these kind of the patient when we have dislocation?
No, sir.
Why?
No, sir.
More chances of injury to the neural tissue.
Yes, more chances of the injury to the neural tissue. So occipital traction is contraindicated. So we are going to operate now this occipital cervical fusion technique is there. So what are the indications of occipital cervical fusion? One, we have discussed when there is a bilateral ligamentous injury post-traumatic. And second, we have seen this occipitocervical dislocation is there, occipitoatlantal dislocation is there. These are same that post-traumatically. What is another indication?
Dislocation with neurodeficit.
It is same. Irreducible.
Irreducible, yes.
Irreducible Atlanto. There are some says that add is there. Then we see it. What is 23? Anyways, one indication is that post-traumatic ligamentous injury, that is unstable ligaments, and second, Atlanto-Occipital dislocation. What is other indications are there? This is only one. We can do only in the post-traumatic patients, OC fusion.
Sir, in tumor patient are congenital anomalies.
Excellent. There is a congenital anomalies. What kind of congenital anomalies are there?
Down syndrome.
Flipperfail. Flipperfail.
Yes.
Sir, Down syndrome में हो
Flipperfail.
सकते हैं?
Sir, good evening, sir. Sir, in bow hunter syndrome, sir, we can do OC fusion. Sir, this is a case, bow hunter syndrome. We operated in our Christian Medical College, Vellore, India. Sir, in this case, patient having a left cerebellar hemisphere infarct was there, and he went various medical colleges. They planned for doing decompression of the posterior fossa, but when we saw there is a scoliosis there is present in the cervical area. And we see that the vertebral artery getting compressed, one side getting left side getting compressed because of the dynamic flexion extension we saw on the MR angiogram. We saw there is a compression on the left vertebral artery. So we started doing a OC fusion in that case, and patient improved, sir. Bow hunter syndrome. It's a bow hunter syndrome. Yes, sir.
Yes, you can do. You can do. There are a lot of indications there. Congenital absence of C1 you can do. Winter syndrome you can do. You can do C1 multiple fractures are there. C1 is not there. You can do tumors. Patient in the case of tumor, the craniovertebral junctions tumors are there, and there is a huge tumor that is from the involving the junction. That you can do post-operatively after taking out the tumor resection. You can do occipitocervical fusion. Lot of tumors are there, like the chordomas are there. You can do. Suppose that you are doing and their C1 has been damaged, and the tumor that is there that is involving the C1 and the C1 arch, that both are damaged. Again, you can do this occipitocervical fusion. So there are a lot of indications there. So not only the trauma patients, we can do the OC fusion. Okay. So this is the landmarks that we have to know, because the main thing that we know to understand, the need to be understand, that is the occipit. Otherwise, the spine we have done. If we are putting the screw C2 from the occipit to C2, we know where in C2 we have to put the screw, either in the pars, either in the pedicle, either in the lamina. We know. In C1, we can palm screw and the lateral mass screw. In C3, we can put in the lateral mass screw. From subaxial spine, lateral mass screw is excellent. So in occipital cervical fusion, man in the occipit, and this is very easy, you have to know. This is the landmark that is called the superior knuckle line. We have to see in the posterior superior knuckle line and the inferior one. These are the ridges, central ridge, because this is important this way, because this part of the bone that is centrally here at the occipit, it is most thick part. The thicker part is this one. And we have to place our plate here. Okay. It is not more above to this one. superiorly, it is not more displaced downward. Because when it's more displaced downward, can compromise the foramen magnum. It is more going upward at the level of anion to the above this one. There is a chance because it causes some irritation over the skin and infections are there. Second, suppose that if we are going superiorly, some later on patient can have the problem in the occipital area, then again it will be difficult for us. Okay, so that's why this line is important, because in the mid of this one and literally superior knuckle line, it is the thickest portion of the occipital bone. Then we talk about the males, the diameter, the thickness is about 12 to 15 mm. When we talk about the females, it is about 10 to 12 mm thickness of the occipital hair. So these lines should be memorized. Okay. After that, when we are doing this one, we have multiple or 2 to 3 options of OC fusion, occipital cervical fusion. One is the keel plate to the C1 fusion that we call. We have to place a keel plate here and then we call C1 fusion. Second is the occipital condylar plus C1 polyaxial screw fusion. We will not place the key plate here. We put the screws over the condyle and then we connect the C1. That is called the occipital condyle C1 polyaxial fixation. And third technique is there, transarticular C1 condyle screws are there. It is the same that as we have seen in the transarticular screw of C1, C2. So there are 3 types of, you can say, the fusion. The standard is the OC fusion, occipital plus C1, where we place a plate here that we call the keel plate is there. There are a lot of different plates are there. We have to target of the midline that we have seen, that is the superior knuckle line and little bit inferior to the anion, then we have to place that plate area. It depends on you that what kind of a plates you are going to choose. So let's see, these are different plates. These are multiple plates are there that are being placed over the occipit. Is up to you. This plate, this one, and this one. These are different kind of keel plates are there, occipital plates, you can say, that are plates. And there was previously in the past areas, there was some long plate like a rod here. Look at here. There was a long rod like, and same plate was placed from occipit to C1 and C2. Single plate, not like this one. And there was a plate that single plate was there bilaterally, one plate attached here and second end here in the C1, C2. That has been now obsolete there. There's no in that plate now. So these are different plates. It's up to you which you are going to place. These are 2 screws are there. These are multiple screws. 5 screws are there. 4 screws are there. Okay. So it has been discussed that some portion of occipital bone, you can drill that portion, the superior cortex of that one. Then you can place the plate because it shouldn't be palpated and visible to the, you can see the bone, and it shouldn't, we can irritate the skin. So it is a different view, it's up to you. But you can plate at the middle thickness, that is about, the male, it is about thickness is 12 to 15 mm, and we talk about the female, it is about 1. We have to, after giving incision and opening of this all occipitocervical junction, I am not going to this step by step because previously we have done all exposures of craniovertebral junction. After exposing this one, we have to place the plate first on the occipit in the midline just below to the anion. We have not to place on the anion. Suppose that this kind of a plate. With the help of marker, we have to mark, and then we'll have drill. You can mark the central, you can say, the screw of this one. After that, you can mark bilaterally, lower one and this one, because this will give us idea later on that we have to, where we have to place the plate. Okay. We have placed this plate. We have made a drill hole over here in the center one. Later on, we have made this hole. Okay. Why we are making this? Because it gives us idea that later on, suppose that when we are seeing that this place is not centrally placed. So central hole will give us idea that we are there on the right direction or not. After that one, I told you that in the male, we have the thickness of about 12 to 15 mm, that area that is superior knuckle and that the central most thickest part. And second one is the female has 10 to 12. But the standard is that when with the help of drill, we have to measure this one that look at here. This is the knob. It is about 8 mm, 8 to 10 mm is there, but our target is 8 mm. You have to drill the 8 mm. After drilling till that 8 mm, what happens with the help of filler, or you can say this is the ball point of their filler is there. You have to insert that filler. You have to see the cortex over there. That is, it is purchased or not. If it is not purchased, it means you have again some area that you need to drill. That is about further 2 mm. First, we have to drill till that 8 mm. That is standard. After that, we feel that it is purchased or not. That is the outer cortex. Look at here, this one, it is not purchased. When it is not purchased, again, we have to drill for the 2 mm. Now it will be 10 mm. Not more than 10 mm we have to drill. Why? Because 10 mm is the standard. If you are going to more than 10 mm, it means sometimes the bone is thick, thin, but lately the bone is more thin as compared to the central one. So that's why the 10 is standard size. After drilling the 10 mm, we have to look at hell. We have previously in the previous slide, this is not purchased. Then we drilled 2 mm more. Look at here, 10 mm. Now it is purchased. When it's purchased, we have to put a central screw over there. Previously, we have marked with the help of drill. We will place the central screw. Now it will be easy for us to do this one. The other screw will not place. Why? Because later on we will feel that this cervical screws are more lateral or more medial. According to that, we can move this plate easily on the lateral side, right side, or the left side. It will be easy for us. Okay. So this is the plate we have placed central screw, and these are, you can say, the mostly it has 5 holes are there. The central holes are equally the central holes. It is considered 1, 2, 3, 4, and 5. When we are doing place centrally hole first, these, then you have to do a hole number 2, and then contralateral holes are there. Okay, like this 2, 4, 3, and this one. In this way, counter holes you have to drill and then fix. When this place has been fixed and you have drilled that one, screws has been put it down. Now what happens? What we have to do? Now it's up to us. What we are doing? Occipital plates has been placed that we call keel plate at their area. With the help of Siam, we have seen that they are purchased properly and there is no any. What kind of a screw we have to place that one? Yes, please. What kind of a screw? What kind of a screws you have to place in this one, put in this one? Yes, a small cannulated screw. Dr. Salim Habib, you loved cannulated screw, I think, and you love cannulated screw as well. Why cannulated screws? That we call, I think, high pitch screws are there. What mean by high pitch? They are at the area of posterior side where there is a tip of that one. There are sharp, but the distal area that is tip, the proximal area from the start to the proximal area to distal, and between that there are sharp and ringed or have a lot of sharp rings, but the distal area is blunt. Screw distal area is blunt. Why blunt? Because it's going inner side, that's blunt. I think they are called high pitch or same kind of name is there. Okay. The tip should be blunt, not sharp, as the other screws what we put in the C1, C2, these are not same. So these kind of screw we should put in this one. Occipital plates we have done. Now you know very well that when we are doing narrow pitch, yes, you are right, Dr. Isra, thank you. Not high pitch, these are narrow pitch screws. Thank you, Dr. Isra. So it means the tip will be blunt, this kind of area. This is the area that will be sharp, and the narrow sharp will be there, and the tip will be blunt. That is called the narrow pitch screws. Okay. So when we talk about occipital has been done, now suppose that C1 is absent, we will omit this C1, we will not put the screw in C1. Now we have options that we have to put the screw in C2 and C3. Can anyone tell me in C2 where you will put the screws? You are all expert now. I think you all are expert in C2 and subaxial spine. So you know very well that where we have to put the screw in the C2 and subaxial spine. So if suppose that I am putting the screw in C2, pars interarticularis, transarticular. Transarticular, why you will put in the transarticular, my dear? I am talking about C2 only, not C1. Transarticular is bilateral from C2 to C1.
Sir, because the bone is thick here.
Vertical, yes.
Because the bone will be thick here and it will be more stable if we pass the screw over here.
If you pass the screw transarticularly.
Yes, sir.
From C2 C1.
Yes, sir.
Then it is transarticular C1 C fusion. It's not OC fusion.
Yes, sir.
We are if I am putting the screw in C1, then occipit to C1 screw is there. In C1, there are two options. Either we have to go for the lateral mass just below to the you can say the posterior C1 arch, either to the palm screws, that again the lateral mass. We have two techniques.
Yes, sir.
So where we are you are saying that transarticular in C2, it will be C1 C2 fusion. Occipit fusion screw has been placed. Now you have to place the screw only one place is there. Yes, you can do when there is an extension injury is there. Suppose that C1 is injured. You cannot put in the C1. You can put in the C2. And suppose there is extensive injury over there, and you can also put them into C3. But it will be not transarticular. It will be isolated screw that will be you have to put in the C2 and C3. There are three options. In C2, what kind of a screw placement is here that is shown in C2? Dr. Sana?
Yes, sir. Pedicle screw.
Yes. What kind of screw?
Sir,
Yes,
above
Dr. Sana?
yes, sir, above picture is showing pars.
This one.
Ji, pars.
This is pars. How this is pars? How this will be pars?
Sir, transpedicular lag raha hai.
Transpedicular screw that is going from the medial cranial side, medially going there. Pars will be not here. Pars is posterior. Yesterday, I again told you, repeated that pars will be like this one. This will be like pars vertically, because this area is pars. Okay, this area is pars actually. area in between the superior articular facet and inferior articular facet. So why we will go to the medial side? If we are going to medial ankle, this is the area of, you can say, the pedicle of C2. So if you are going medially, though the direction of this one is not accurate, it should be more medial like this one in this area. I think that's why you are confused, because it's touching some part of the pars. But again, the pars screw will not be the cranial to the superior articular facet. Yesterday I told it is more caudal. The pars screw is more caudal, the more dorsal. That is more closer to the inferior articular facet, like that of the transarticular screw. But look at here, that this screw is very attached at the superior and cranial side of superior articular facet. That's why it's the transpedicular screw. Good. So the transpedicular, when we are putting the in situ screw, we have three options. One is the transpedicular, second is the pars, and third one is translaminar screws. Okay. When we are putting into C3, this is C3. I want to ask the question, but I again replied myself. So what kind of screws are there now? This is C3.
Now this is transarticular, sir.
Lateral mass screw.
Who said lateral mass screw?
Sir,
Who is there?
Dr. Sana.
Dr. Sana, you said lateral mass screw?
Yes, sir.
Excellent. Excellent. These are lateral mass screw. These are not pars screw. Pars screw will be vertical like this. Sorry, not vertical, horizontal. Like this. When we talk about the pars screw, they will be like this one. Not this one like this one. They are laterally going. So these are lateral mass screws. Subaxial spine, always remember, we prefer the lateral mass screws. Okay. So look at here. It's going and laterally going. It is a lateral mass screws are there. Subaxial spine, mostly lateral mass screw, mostly because the pars and the pedicle is not strong. Look at here, this pedicle and this pedicle. That's why we prefer the lateral mass screws as compared to the C2. So these are lateral mass screws. When we are putting the screw in C3 and subaxial spine, we'll put the screw in the lateral masses there. Okay, got it? Any confusion? Any confusion?
No, sir.
Subaxial best in lateral masses, excellent. C2 pars, C1 lateral mass. We follow this in our suite. You are right, and you are following in excellent way. And I also prefer the same. You can say the protocol in C1 lateral mass or palm technique, in C2 pedicle and subaxial lateral mass. So this is important of this one. So any question up to here? Any question up to here? No? No question, please. So when we have placed the subaxial screws in C2, and this is just a demonstration of some kind that we have resected a tumor. This is the picture. We have resected a huge tumor at the craniovertebral junction. We have removed the arch of the C1 that has been engaged by the tumor, that is damaged. Then we place the screw over there. That is the one picture, C2, C3, C4. Okay. So these are the placement of the screw. After that, you will place the rod like this. You will curve the right, the junction, and then in this way. Okay. So these, I have shown you previously that there are different types of plates, occipital plates. It's up to you which you are following. So we have done the OC fusion, occipitocervical fusion. What is the drawback of occipitocervical fusion? Anyone?
Limitation
What
of
is the
range of
drop?
movement, sir.
Sorry?
Limitation of range of movement, sir.
Excellent. Limitation of range of movement. Uh, good. How much? Which is movement is most limited, restricted?
Sir, flexion and extension.
Flexion.
Flexion, extension. Excellent. How much?
Sir, almost 50%.
Standard is 30 degree, okay? 30
30
degree
yes, 30
flexion
degree.
extension, lateral bending 10 degree, lateral bending. Lateral rotation is 8 degree, okay? Flexion extension is mostly restricted by this OC fusion, that is 30 degree, lateral bending 10 degree, lateral rotation 8 degree. Another drawback is that mostly sometimes what happens is screw is more purchasing and going inner side to the brain, it can hurt to the brain as well. There is injury to the brain and dura. Second thing, we are placing the occipital plate. Suppose that some patients later on they need the occipital decompression, craniovertebral decompression is there, then it will be difficult. We have to remove that plate. Okay, these are drawback of this surgery. Okay, when we see these drawbacks, so then we have some alternatives. What are the alternatives of this one? Anyone? What are alternatives of this one? What are alternatives of OC fusion? Occipitocervical fusion. We have two alternatives. So anyone who can tell me this one, then we will end the class. What are these screws? What is this fixation and fusion? What kind of? Anyone who have the idea?
Transarticular, sir. OC.
Which one is the
Transarticular.
transarticular?
Sir, this right side, sir. Right side one. The screw entering
This
into the
one?
condyle. Yes, sir.
This one is transarticular.
Yes, sir.
Excellent. Transarticular screw. Same in the same way that we have seen in the transarticular C1 C2 fusion. In same way, you have to put a screw in the C1, then the condyle, single screw. That is called transarticular screw. Okay, we have alternative that one. Single screw, no plate, and that one, that is all. Second technique, what is the second alternative? What is this kind of screw is there?
Polyaxial.
Polyaxial, excellent, Dr. Yusra. Polyaxial C1 screw. What about this one?
Lag screw.
Occipital condyle C1 polyaxial screws. Excellent, thank you. So the second alternative to that, we will not place the keel plate over the occipit. We can do the screw that is in the condyles. Transcondylar screws will be there. In the midpoint of this one, look at here. This is midpoint of condyle. How we have to see the condyle measurement? The width of the condyle is about 25 mm and the length is about, I think, maybe I wrong. That is about 11 to 12 mm. Midline to this one, foramen magnum, in like this way, center. Lateral to the this one about 1 centimeter. Then we have to put a screw in the mid of that one that will be directed to the condyle. What will the trajectory? Trajectory will be similar to that of C1, about 12 to 15 degree medially, and superiorly you have to go. Then you have to place that screw in the condyle area. Okay, and the C1 screw that will be in same way. This is the you can say this is same condyle screw. In C1 screw, you have to put in same way like the lateral mass screw or the pump technique we have discussed previously. So these are called condyle C1 polyaxial screws. Okay. So alternative, we have two techniques. One is the condyle C1 polyaxial screws, and second is the trans articular C1, and you can say the condyle technique. That is similar one. Single screw you will put down in the mid of, you can say the lateral mass of C1, then goes upward at the degree of 45 degree above, till that it touches the uh, 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 half of the condyle of that one. It is going purchase above, you have to see that one. But if it is at the half of the condyle is there, that is enough. You can put that screw. So there are two techniques of this one. So this is all about ossifusional techniques of occipital cervical dislocation management. Any question?
Sir, I have a question.
Who's
Sir,
there?
Sir, Dr. Sana.
Dr. Sana? Yes,
Sir,
Dr. Sana?
which of the technique from posterior cervical wiring and fusion is important regarding the exam point of view? Please guide.
Sorry? Sorry?
Wiring technique, posterior cervical wiring technique
Yes.
is important.
Sir,
Technique
sir,
is
he's
important.
asking about the Gallis fusion, sir. Posterior Gallis fusion by putting a posterior.
Yes, the wiring technique, sublaminar wiring, and with the graft over there. So,
Yes, sir.
hello?
I guess she's asking about the Sontag technique that we use.
Sondage technique and
Dr. Sana, were you
Gallis, that
asking
is
for
the
Sontag?
helix, and
Yes.
remember one thing, that the Sondage and Gallis and helix, these are kind of that has no not available right now in no one is doing this one because they have no any advantage
Sir, we do, sir, in our
stability and
institute.
fixation fusion. Sorry?
Sir, we do in our institute. In CMC Vellore, we do, sir, Gallis fusion, sir. Regularly, we do C1, C2. We put a posterior superior iliac spine bone graft, and we do Gallis fusion, sir, with Atlas cable, sir.
Ideal, I'm saying ideal situation. Suppose
Ideal,
that
sir, we
if you
do,
are
sir.
not doing, C1, C2 fusion, the goal stacking and transarticular, then we have the
No, sir,
second
we are doing,
option.
sir. Yes, sir. We are doing transarticular along with Gallis fusion. Both simultaneously we are doing. The concept behind it, my HOD says, Krishna Prabhu sir says that anterior Dennis anterior column and middle column will be fused by the transarticular, and Dennis posterior column will be fused by this Gallis fusion. Though it will be 360 Parthia 360 Dennis all column fusion. The concept is
Yes,
to fuse all the
but
columns, all the Dennis columns.
this is
The concept is,
associated with the transarticular. You can do that and put to the graph. That is called the Gallis. But she is talking about only the sublaminar wiring.
no,
Yes,
only
am I
sublaminar
right?
wiring is not a good construct, sir. Only sublaminar wiring is not a good construct. It's never a
Yes,
good
why,
construct.
what I am saying. Dr. Sana, are you talking about sublaminar wiring?
Yes, sir.
And the Sondage technique?
Yes, sir. For exam purpose.
No. For example, first don't do straightforward in the first option. Don't place that one, the sublaminar wiring. No, not at all. Not at all. Always say that I will go for the C1, C2. Either it's the C1, C2 fixation fusion or the transarticular. In transarticular, you can put a graph. That is the Gallis technique. Is right. But not sublaminar wiring. Never say sublaminar wiring because you have a lot of options nowadays in the posterior. If you are not going to the transpedicular screw in the C2, you can put the screw in the pass. If not pass, the lamina. If you are not doing the C1, C2, and that is going harms, you can do the transarticular approach. And then by this one, if you are not distracting the fascial joint, only do the transarticular associated with the graph putting, that is called the Gallis. They are saying, okay. So never say the sublaminar wiring.
Thank you, sir. Thank you.
Okay.
Yes, sir.
Because there is no any importance of sublaminar wiring nowadays. Either you have the last option, then again it has no options.
I think Dr. Itzaz, she was asking from an exam point of view, and you know, and I know, and I think a lot of our colleagues from Pakistan know that when we do not have this option of C1, C2 fusion and fixation, then we do get to the Sontag technique as a last resort. So I think, Dr. Sana, from an exam point of view, it would still be useful to know. From a clinical point of view, it would strongly depend on the kind of setup you're working in and what is the institutional policy. But yes, Dr.
But
Itzaz is right. It's not the standard anymore because the construct is very poor in terms of stability. But
what I
from the
what
exam
I
point of
observed, my experience is that when I went in the exact exam, there was a case of odontoid fracture. There is a disruption of ligamentous injury. Examiner asked me what are the different options. Listen the question. What are different options to deal this one? I started that we have anterior and posterior option. Anterior we can place that the anterior odontoid compression screw. Options. The posteriorly, we have a lot of options, C1, C2 fusion, transarticular, these are techniques. Also, he said that what you will do. I said that as the ligamentous is disrupted, I will go for the C1, C2 fusion, that is the gold technique standard. He said, then if you are not going to do that, I said that I can do the transpedicular, if not do, I can do the pass, if not do, I can do the laminar. He said, then no, you cannot do. Then I said, what other options? I said that I have the option of transarticular. He said, no, apart from transarticular. I said that, sir, we have the option that is not standard, but I will not use. That is the sublaminar wiring. So you have to the answer in such a way that examiner should know that what he or she want to deliver. Okay. Yes, you can say, sir, there is an option of sublaminar wiring, but it's not standard and it has not good stability in the construct. That's why, but it is the last option when all options failed. But usually the C1, C2 are transarticular. Mostly it is successful and surgeons are doing. I think you are clear now, Dr. Sana.
Yes, sir. Thank you so much.
This was my experience in exam, what I shared with you.
I think, Dr. Itzaz, we should wrap up the session. It's way past our usual time, and I appreciate that it's your clinic time as well. And since there were interruptions, everyone, I would put up the recording after I have edited the version that was recorded in my computer. The live recording would not be available for too long. So, Dr. Itzaz, are you with us?
Yes, I am here.
Okay, so anyone, if you have any questions or any feedback, anything that you want us to cover in the rapid clinical review, even if it is from an exam point of view for the next 2 weeks, then let us know on the group. And this is a wrap.
Thank you so much. Thank you, everyone.